peri-implant disease once your patients have contracted the condition. So now we're going to consider these points, these learning objectives for the diagnosis of peri-implant disease and its management. I want to explain the latest concepts and protocols used in the management of peri-implant disease, rank the various forms of this disease, this peri-implant disease, according to its severity. And I think already a number of you are now aware that this is less severe in the mucositis and the mucohyperplasia, but we've got more problems when it comes to peri-implantitis. We have an early onset, a moderate onset, and advanced onset. You're going to recall the various protocols and ideas I'm going to be suggesting to you now, and you're going to differentiate between the various types of peri-implant disease according to their clinical and radiographic appearance. Okay. Right, so the first thing about all of this is to have a preventive measures before you even start the implant placement. To have a preventative scheme in place to actually prevent this, because once somebody has peri-implant disease, there is no going back. So you want to have what they call a PASS, or a pre-treatment, a risk assessment and selection for your patients. And as I said, we've discussed this in other lectures. You want to residue periodontal pockets with bleeding on probing are risk for peri-implant disease and implant implant loss. So if they've already got some active form of periodontal disease or deep pockets, it may not be active, but of course if they've got deep pockets, then they're going to be prone to this disease. On completion of active periodontal therapy or retreatment and periodontal re-evaluation are commenced before implant placement. So you've got to do all the periodontal cleanup before you place your implants. Treatment and maintenance, that's the ongoing thing. That's an SPT, or supportive periodontal treatment as it's called. But we have one for implants, which is a supportive implant care as well, especially if you've done any kind of surgery to try and treat your periodontitis, or sorry, your peri-implantitis. You need to follow that up with a maintenance scheme or program. And the intervals of that maintenance program will depend very much on the patient's risk factors for developing the condition. Often dentists pull a figure out like 6 months. I'll come back every 6 months. Or some patients need to be seen and cleaned every 4 to 3 months. Others can get away with once a year. It has to be patient specific. So implant recognition and maintenance is all about early recognition of clinical signs of peri-implant pathology and maintain or establish peri-implant health. That's what it's all about. And it starts off with establishing some sort of baseline radiographic baseline. Now, for myself, in my own practice, I establish my baseline after 6 months. I don't try and establish a baseline on my patients at fitting the restoration. Some people take an X-ray at fitting the restoration to check that it's all down, but the restorative protocols I use, I don't need to do that to check my abutments are down. And the reason I don't take an X-ray is because we've already said you're going to get up to 2 millimeters of bone loss in the first year in any event. So all you're doing is seeing that first 2 millimeters. You want to establish the stable bone level around your implants. There's no point in establishing a bone level that isn't stable. Your baseline needs to be stable. So you'll find that after the first 6 months, the majority of the bone loss will have occurred. So it's not that it takes, it had a gradual 0.5 millimeter every month up to a year, and then you get your 2 millimeters lost. You'll find that most of it occurs actually within the first 6 to 8 months of placing it. So if you get the patients back after 6 months, and then establish your radiographic baseline. And if it's a full mouth or a large restoration, I'm likely to really just use an OPG. It's not 100% good at determining that, but it gives you a rough idea because at least you have screw threads to look at. If you want to be very precise and pedantic, there's nothing the matter to taking an individual PA of every implant, and that'll give you the best view, the best results ever for your bone level and establishing your level of bone. But at the very least, take an OPG at the 6-month period. Some practitioners have started to use their CBCTs for this. I'm not sure how advisable that is in terms of ionizing radiation and IRMA and ALARA and all those things. So I would be very wary about using CBCTs to monitor the bone level around implants. So this supportive periodontal therapy, so you want to update the medical and dental history and inspect your implant prostheses when they come back. Evaluation of iatrogenic factors such as cement, remnants, misfits of prosthesis, implant prosthesis, proximity to other implants or teeth with insufficient access for interproximal cleaning. So can the patients maintain it? So they come in for their checkups, just obviously you'll check their medical history, and then you'll check that the thing is still firm, nothing's come loose, the thing doesn't come off when you tug at it. As I said, sometimes they're loose, the patients aren't even aware of that. And then you just check that the patients can keep it clean and there's no areas of plaque buildup due to the design of your prosthesis. Now, perhaps more important than taking lots of x-rays every time they come is to do regular monitoring of the peri-implant tissues for the presence of plaque, increasing pocket depths, and bleeding on gentle probing. Now, the peri-implant soft tissues are not attached to the implant. They're very soft and delicate, and it's very easy to take that probe and just shove it right the way down to the patient's bone. Now, when you took a periodontal probe around a tooth, you get down to the base of the sulcus. You've got the attached gingiva there, and it doesn't go any further because you've got fibrous attachment. You have to actually, physically, you'd have to actually push the probe, rip the attachment to get down to the crestal bone level. With an implant, it doesn't take that amount of pressure at all. It's very easy to get to the crest of the bone because there's no attachment of the soft tissue. So you want to use a very gentle 0.25 newtons, very gentle probing force. And you're looking for things like bleeding, as I've said, and suppuration. And you can also look for radiographic evidence of bone loss. After taking my baseline, I would most likely leave it another year before I take another radiograph to see because there might be a bit of bone change just by still remodeling if I'm seeing it at 6 months or 8 months. So give it another year and see where you're at there. If it's only gone about another millimetre or half a millimetre, I wouldn't be too concerned. I'd send them away for another year, especially if there's no soft tissue inflammation. Obviously, the soft tissue inflammation, that's a different kettle of fish altogether. Without soft tissue inflammation, that is just bone remodeling. With soft tissue inflammation, that could be bone remodeling, or it could equally be peri-implantitis going on. So you're going to monitor changes in the pocket depths from a fixed landmark. Now, and this landmark can be regularly done when you're doing your examinations. So maintenance of peri-implant health, I would set a minimum recall of 1 year. That's your, you can't go 2 years. It's pushing it. Minimally, I'd like to see my patients once a year to come back. If they've got a very complex restoration, if they've had a particular history which is worrying, they've got diabetes, or they've had previous implant losses, I might want to see them more frequently than that. but that goes into your risk analysis. And they need to have reinforcement and professional cleaning on a regular basis. You need to have a hygienist, or to send them to a practice with a hygienist. I, at the moment, do not have a practice with a hygienist, but I send my patients to practices that have hygienists, and they look after them regularly and keep them nice and clean for me. And then I see them on a yearly callback and see what they're looking like. Okay, so it's most important to have this maintenance thing going. So, and I would say as a result of that, I've lost very few implants through peri-implantitis, and I have very few patients actually coming into the surgery with peri-implantitis. And those of you who are my students will know from all the cases that we see, only 1 or 2 of them have peri-implantitis, far lower figures than the literature would suggest. And that's down to regular maintenance of the implants, regular scale and polishes with the hygienist. So prevention, well, treatment of these pathological conditions, bone loss, remains a topic of investigation. And as yet, there is no definitive treatment for the treatment of peri-implant bone loss. There is absolutely nothing in the literature that shows that one treatment modality is any better. And you'll read about things, people using membranes, some people use a bone substitute, some combine them, some was it with a laser, some don't bother with a laser, some worry about metal scalers, some don't. You've got titanium brushes. There's a whole plethora of different devices to clean implants and try and regenerate bone, but there's no evidence that any of them work or how they work in the long term. So failing implants, as I say, do not cause pain until it's too late. So that's the reason for having a recall regime. The prognosis of the affected implants will be contingent upon early detection and treatment of the mucositis and peri-implantitis. So you're going to get the best prognosis the sooner you identify it. The sooner you get in there and do something. If it's very early peri-implantitis, the sooner you or your dentist pick it up, the better it is for everybody. The worst thing is for a dentist to refer back a patient after 2 years of peri-implantitis, and there's just been a whole heap of bone loss in that time. And it's virtually impossible to regenerate it. So regular checkup visits and lifelong supportive therapy is an absolute necessity for implant patients. So when you're doing your consent, and in our consent letters, we say that they are committing to that lifelong supportive regime. There's no let off for that. That is it. That's if you want implants, that's what it needs. Now, I bring that up in some countries, in some groups, and they turn around and say, oh, but if I told my patient that, they wouldn't commit, they wouldn't buy an implant, this, that, and the other. Well, okay, you will have to deal with the fallout when it comes back, or you have some very unhappy patients. I find if it's done correctly, patients are very appreciative, and it can be quite a practice builder, especially when you start to do quite a few implants. You can imagine you can have a very, very busy maintenance clinic going on, and it can generate a stable income for your practice, and also circumvent any expensive repairs and rehabilitation treatments that you'd have to carry out otherwise. So on one thing, you make money and you have a happy patient. On the other side, you have an unhappy patient and you lose money. So to me, it's a no-brainer. Put in a maintenance program. Sell the maintenance program when you're selling the implants. Give the first year's maintenance free. These are the things you can do to keep contact with your patient and keep them engaged in their treatment. So what you do an examination, you do reevaluation, you diagnosis, you motivate patients, and last and foremost, you carry out some treatment of the infected sites. And hopefully that treatment is very minimal. So these are the sorts of things you get. You can see there's been an abutment come loose here. This one hasn't been kept terribly clean. There's a build-up of material here. This sort of thing would go back to the technician. They separate it, they clean it, they grip blast it, and this comes back looking as good as new. I always show the patients this, and I show them the build-up of the deposits. I explain what's going on. I make them aware that they have not been looking after their implant. This may have been worsened because this may have been loose for a time. Sometimes I have to replace the post screw, so I always keep a stock of post screws in. And you know, if that thing's been loose and wobbling around on the implant, what's the chances that that fine thread might have been damaged? And then I use that fine thread again, and the stress in there, maybe that's going to predispose to later on, the patient won't come back with that, the patient will come back with a fracture. And now you've got half a screw stuck in your implant. Whereas at this stage, it's a good opportunity to just throw that screw in the bin and give them a brand new screw. And of course, you can charge for that. That's chargeable. They've worn something out, it needs to be replaced. And most of them are quite happy to pay for the replacement screw. So these are all, you know, maintenance doesn't need to be an odorous thing that you have to do, a costly process. It can actually generate a lot of goodwill, and it can generate further implants as well, because people, if they've had one implant, sometimes need another implant later on. If you're doing the maintenance, then likelihood is you'll get to do the implant. Whereas if the patient's wandered off somewhere else, you might lose that ability to do that implant. Okay, so because peri-implant diseases are caused by bacteria, the rationale behind the treatment is quite easy. You're just going to do things that are going to reduce that bacterial load. And you want to then establish a healthy clinical environment and prevent any further bone loss. That's the whole rationale of our treatment. So the stages of therapy will always be some sort of mechanical debridement to remove the biofilm from around the implant in the peri-implant pocket. So that may mean that you have to unscrew the abutment, take the abutment off, send it for cleaning. That may also mean you have to modify the prosthesis. You may have to improve cleaning and access, but that would show up at the review appointments. Antiseptic treatment. Now you're going to be using some sort of antiseptic to actually decontaminate the surfaces, especially if you're doing cleaning. If I'm just doing an abutment, then often I'd prefer, if I think the abutment needs cleaning, I'd rather remove the abutment and actually get the lab to clean it, or we put it in disinfectant and the lab take it and they clean off all the stuff, they polish the surface, and I know it's been completely decontaminated. Unfortunately, teeth, you can't do that. Teeth, you can't take the top of the crown off and send it to the lab to be scaled and things like that, yeah? So that's not a possibility with natural teeth, yeah? Now, the next thing is antibiotic regime to eliminate infectious bacteria in the surrounding peri-implant tissues. Now, you can use antibiotics, and in fact, oftentimes, if they've got a full-blown peri-implantitis, you will need to treat that as well with antibiotics, because you've got an osteitis going on in the bone. So you need to treat the osteitis. You've got infected bone going on, and you need to treat that. But giving the patient antibiotics without sorting out 1 and 2 is a waste of time. Because, you know, so patient comes in with some infection around a tooth, take some antibiotics, go away. The infection will come back and the patient will continue to lose bone. And then all you will have in your notes is a list of 5 or 6 visits where you've prescribed antibiotics to no avail. So you're going to be done for overprescribing and not providing effective treatment. So what you do is antibiotics are part of the whole stages of the therapy, not just given to say goodbye to the patient. And then you have to assess it for whether you're going to want to do some regenerative work or resective surgery to establish a new bone implant interface. Now, when you start using grafting around an implant, bear in mind that it hasn't really been shown that just because you put some graft around your implant surface, it's going to reintegrate. That's highly unlikely, in fact. So early diagnosis, important to diagnose and treat peri-implantitis early, as bone loss is non-linear. Remember, it increases with time, it gets worse the longer you leave it. So if you take away anything, you really want to sort that out quickly. So the advantages of a surveillance type of scheme, it's economical for you. If you implement one, it can generate income, it can generate more implants. It's also economical and value for the patients, because if they lose their implants, it's going to cost them money, and it has also a medical value as well. It's got a dental value, it helps prevent disease, right? So you want to prevent peri-implantitis. So annual monitoring the surface of peri-implant reduces the financial risk of implant failure during an acceptable period of time. Obviously, if a patient loses an implant after 8 to 10 years, and they're sort of more amenable to the idea of having a new one. Monitoring the surface of the peri-implant is better to protect against, as I say, medico-legal responsibility of dentists, and could save you money and a lot of heartache. On this side here, we're going to save teeth and bone by doing this. So better diagnosis, better treatment choices, and faster treatment. You're going to identify something far earlier, and you're going to preserve the implants and teeth and everything else. Because also, if they're if they're a dentate patient, of course, you can tie this in with their normal periodontal treatment as well, and that's a double whammy. So, peri-implant disease. You're really looking, the main indicator is for bleeding on probing. As I said, there's not much pain unless somebody's got a loose abutment or something. It's this bleeding on probing. If you see the presence of suppuration, then that's another very strong indicator, and eventually bone loss, but you're going to need to take an x-ray to see that, and you're only going to do that if you've got the other two things present. If the implant's firm and there's no mucositis going on, then you're likely to be quite happy to put the x-rays off to an annual review on the x-rays. And again, the first set of x-rays can be free, but then after that, every year, they have some maintenance x-rays. And again, there's no harm in charging for those as well. So, you know, it's not necessarily, it's going to cost you money, it can generate you some money. And if you have a hygienist who can take x-rays, that's even better, because it keeps your hygienist busy. So the presence or absence of bleeding on probing is determined by waiting 15 seconds following light probing and reporting either a positive result if bleeding occurs. So you just very gently, with this 0.25 newtons pressure, probe the tissues. You don't ram the tissues down so the patient jumps out of the chair. You just very, very gently, and you wait then about 10 to 15 seconds to see if you've initiated any bleeding. So bleeding and or suppuration is the earliest clinically detectable stage of the disease and avoids unnecessary exposure to radiation. So rather than irradiate your patients every time they come in, go on and do this probing. Now, probing technique. Excessive probing pressure, even with a healthy soft tissue complex, may cause rupture of the fibers and result in a falsely increased probing depth. Probing using a light force, remember, not exceeding this 0.25 newtons, it's very gentle, does not damage the peri-implant tissues. Periodontal probes penetrate close to the bone. If you push these probes down, they'll hit the bone. If access for accurate probing measurements is prevented by the prosthesis design, it may need to be removed. So if you've got a full arch, you may need to take that off to get in there and have a good probe around. Now again, this can be charged for. If they've got an expensive restoration, a full arch restoration, and you need to take an hour to go in and do a full pocket charting around those implants and remove, then you charge them for an hour of the surgery time. Just like when I take my car in to be serviced and they have to take the wheels off and change the brakes, I have to pay for that time for taking the wheel off and changing the brakes. And you might need to take the prosthesis off also to check the abutments are still firm, the implants are still firm. Depth from the base of the implant socket to the crest of the mucosa, you can look at that kind of, you can take the measurement from there. Probing may have to be done with the prosthesis removed, as I said, as it may obviate the probing down the long axis. If it's overhanging, you can't get in the right angle. The level of the crestal soft tissue can be measured using a fixed reference point on the restoration and should be noted as a clinical attachment level. So if you need to measure the amount of recession around your implants, depending on the situation, you can use the probe to measure it from the crown margin, for example, down to where the soft tissue level is. If you want, and if there's actually threads exposed, you've had more severe bone loss, you might see some threads. Well, then you can note how many threads are visible. So it might be 1 thread visible, 2 threads visible, and then in 6 months' time, you can see if any more threads are visible. Now, the probe I recommend for this is this one here. It's the, it has these very fine, it's not the same as a periodontal probe, it's a little bit different. It has these little marks at 1 millimeter, and you need to be able to measure these 1 millimeter marks. And the dark ring that you see is a color probe. The dark ring kicks in at 4 to 5 millimeters. So you've got 1, 2, 3, 4, and then 5. It kicks in. Then 6, 7, 8, then 10, and 15 are your bands, if you like. So this is, it tells you that up on this slide here, 1 to 2, 3 to 4, 5 to 6, and 7, and then so on all the way through. Yeah. So this is, and it's a very fine probe, and it's used in our screening. So you've got 1 millimeter increments, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, so on. Yeah. All right. So 1 millimeter increments, and it measures the periodontal pocket depth, and it can also be used to measure the gingival margin level. And as I say, if you're measuring the gingival margin level, you can measure that from a fixed point from the prosthesis, or if threads are exposed, you can measure it from the threads, or you can count the number of threads for that matter. You don't necessarily need to take a probe to measure it. So you do a measuring point is used, and as I say, from the restorative margin, or you could even go from the abutment interface as well. From the implant abutment interface, or count the threads. So when we get this feedback, we're going to get the first black line remains visible. So we've got the first black line is well visible, that's just mild. The first black line is not visible, that's moderate. And then we've got the second black line is not visible, then you've got a severe case. So this can be used very quickly around your implant restorations just to see what's happening. It's not an expensive piece of kit. It's saving on radiation. It's a very quick it's almost like it's a bit more than a screening. It's a bit more than the periodontal measure that you use for periodontal health, the screening one. It doesn't give you codes in that respect, because the probe that you use for that is a screening probe. It's not used to actually measure the severity of the disease. This probe has got measures on it and marks on it, because you're trying to ascertain the severity of the disease and actually measure how much bone loss you might have or what your pocket depths are. So if your pocket depths are increasing, then you might start to worry you've got periodontal or peri-implant disease. So probing depth examination. The information gained regarding bone depths from probing is not precise. So all this does is give you an indication, but if you really want to know where your bone is, you then move on to your radiographic assessment. So if that probing shows you there's a problem, you then start to take your radiographs. And obviously if you have bleeding or suppuration, and that's elicited either from the probe, or sometimes you can just press your finger on it, and that's enough. You just press your finger, and that's enough to start the thing going. So you want to establish a baseline. So I like to record mine within the first 6 months. I don't do it normally at the connection of the restoration. If I'm looking after students, or the patient is leaving the country, or I'm not going to be seeing them for a while, then I'll do it when I fit the restoration. But I would advise, if there's no, you get to see the bone level when you uncover anyway. You know, you see the bone level when you expose the implant. Why do you need another x-ray? So unless you're doing it to check the fit of the restoration, then give it a good 6 months and then take it. And then you can do a PA for singles, or if it's a full arch, I'll do this. But if I really want to be very sure, I might do PAs of each individual implant. But again, if it's a full arch, then you may have to remove the full arch to be able to position the PA. And a lot of patients are not going to really want to have their prosthesis clipped on enough, maybe half an hour's worth of work for you to get PA. So unless something's really showing up as a problem from your OPG, then I'd avoid full arches on large restorations. I'd avoid PAs on full arch restorations. So bleeding on probing and increased probing depths. This is what we're looking for. So if that initial test with that probe starts to give us any warning signs, then we move on to the next step. Following prosthesis installation, you establish your baseline with your probing. Now you can do that, and as I say, the radiographs can come later. But again, you need to have a consecutive number of radiographs to compare. And I like to leave at least a year between radiographs. And maybe after the first follow-up radiograph, if things are looking really good, I won't even do another one for 2 years. You know, unless there's an actual indication for it. You know, it's as low as reasonably attainable. Remember, you shouldn't be taking them just willy-nilly. Patients come in and get a radiograph because they've had implants. I think it's far better patients come in and have their prosthesis checked that it's firm, and have their soft tissues checked for any signs of inflammation, and to have their probing depth checked. Now, if there's no sign of inflammation around the soft tissues, and if I press it and the patient's oral hygiene's good and there's no mobility, then I won't bother with the probing depths either. There's no need. I would only bother with the probing depths if I start to get bleeding. So if I'm sort of suspicious, drop the probe in, see if you can elicitate bleeding. If you can elicitate bleeding, then go round and do a probing depth and compare it to your original figures, and then take your x-ray as well to confirm where the bone level is. And radiograph should be perpendicular to the implant body to show clear demarcation between the implant threads. A lot of times when you're looking at PAs, what you're really looking at is where the implant thread is in relation to the crestal margin. So it might be that only one thread was above the crestal margin the first time, and now there's 2 threads above the crestal margin, so you've lost 1 thread's worth of bone in the successive radiographs. Now, if you know the pitch of your implant thread, and if your pitch of your implant thread, if the distance between the crest of one thread to the next is 0.6 of a millimeter, say, then you can say that over that period, they've lost 0.6 millimeters of bone, and that you might find is acceptable. But that level of reading, you really need to do on a PA. And I say it might not always be possible. So this is 1 over 6 months. So this would have been maybe been just done 6 months in, and then 6 months further on, and we can see there's been bone loss. Now, this amount of bone loss to me is looking a bit worrisome. because we've had at least the 2 millimeters. I know this is almost going to 3 because I know the length of these threads here. That's why it's important to know your implant design and what the dimensions of your implants are, and if you've got a smooth collar, how much of the implant is smooth collar, and where does the first thread come in? Because if you don't know that, you can't take any measurements. So this is my implant abutment interface. Now compare this to the baselines which were done in July of another case, which was done in 2013, and this was over a year. Now you can see within that year, there's been very little, if any, bone loss whatsoever over that year. So it's been a very, very stable restoration. Now, some of you may say, oh, well, this looks a bit weird. He hasn't put the implant in the middle. But remember that slide I showed you first of all, I prefer, rather than sticking a 4 millimeter diameter implant in the middle of a 14 millimeter ridge, I prefer to have, and not to have an overhang of 5 millimeters either side of my implant. I would rather have 2 premolars with a premolar cantilever forward. This becomes very easy to keep clean. I think somebody's got their microphone on. I'll just find out who's got their microphone on, if they can switch. I don't know who's got them. Go down and switch it off. Right, okay. Sorry about that. I'm going to share the screen again. Right, so basically there's been very little bone loss around that implant over that period, and I'd be very happy with that. And I say I like this design. It's self-cleansing. If the tooth further forward here has got a root filling or has a doubtful long-time prognosis, again, that can be replaced later on with an implant, and then you get a nice 3-unit bridge. The patient gets premolarized occlusion with 2 premolars, and on a marketing situation, I tell the patients, well, I'm giving you an extra tooth for free. They're often very happy with that. And this is just, to me, a better kind of restoration than trying to put a small implant of, say, a 4 millimeter implant into a 14 millimeter space is going to mean 5 millimeters of overhang. And it's a lot more difficult for the patient to keep clean. Whereas here, they can use their floss down here and keep that clean. They can drop their super floss under there and clean out under the pontic. And I actually keep the whole thing as 2 premolars and premolarize the occlusion. So that may seem strange to some of you, but it's really a very nice way of restoring in that area. Again, we have a implant here. It's a short implant, and we're looking at the bone levels. That's just on the crest of the margin here. We've lost maybe a few threads. That's all down. That to me would be all down to just remodeling of our bone. Again, we look at it later on. If I go back to the previous, this one was in 2011, and 2012, a year later, we can actually see there's been virtually no change in the situation at all. It's completely stable. These are platform switched implants, which are very good at maintaining bone levels. Now, this is a situation of an implant which would worry me. I can see there is swelling there. I can see the soft tissue looks red. It looks edematous. This looks very suspicious. And the patient's oral hygiene isn't immaculate. The staining here, this now is beginning to bother me a bit. So that would worry me that there's a problem going on there, and I would want to investigate that further. So the presence of bleeding on probing and suppuration should be assessed regularly for the diagnosis of peri-implant disease. Bleeding on probing indicates the presence of inflammation in the tissue around the implant. Bleeding on probing may be used as a predictor for loss of bone. It doesn't mean to say there is any bone missing, but it's a predictor. If it continues, then there's a chance you're going to lose bone. Suppuration on probing is often a sign of peri-implantitis. It's not a given, it's not absolute. Increasing probing depths over time does indicate there's a loss of supporting bone. And an annual radiograph is used to evaluate the supporting bone levels around the implant, and that limits the exposure. So just to reiterate, when the patient comes in, check them for a loose appliance, check them for any mobility. Then push on the gum around it and see if there's any bleeding. If you can elicit any bleeding, or if the oral hygiene is poor, then go for your probe, go back around and just check your probing depths. If they're increasing, then take an x-ray. If they're about the same, implement oral hygiene instruction, get rid of that mucositis, and then do your x-ray as you would normally do. So if they come in halfway between an annual check, don't rush for the x-rays straight away. So radiography. Now, when you're looking at bone defects around, there's these types. There's a thing called patelliform bone loss around an implant, funnel form, gap form, and that's an interosseous. So these are interosseous bone defects, and this is supracrestal or horizontal bone loss. Yeah. So now there's a correlation between the pattern of bone loss and the etiology of the condition. So this is an example here of our patelliform bone loss. And as I said before, if I move that to there, we can see I've done this diagram where you've got the bone is level with the implant crest still, say about here. This is, and you've lost bone around the implant. So there's like a moat of bone loss around the implant. This is not funneling bone loss, because with funneling bone loss, the bone would come down and maybe buccally and lingually, the bone level would be here. With this, the bone level all the way around is the same, and you've got a moat of bone loss around it. And obviously in this area is filled with soft tissue. So where you've got here, this slightly less radiodense appearance, that's where you've got this patelliform bone loss, where you've got this all the way around it, you've got this defect. And this, as I say, is absolutely diagnostic of peri-implant disease. So here's some pictures that we're showing here, where we've got a patient coming in with peri-implant disease. They've lifted a flap, and we can see here that the crestal bone is high up, and there's like a trench, defect all the way around that. And what you can do is you can obviously take any granulation and infected tissue there, you sanitize the surface of your implant, and I'll just go back one, you sanitize the surface of the implant, and then you graft it with a particulate graft material of your desire, and you pop that into there, and then you suture it all back together. So you've cleaned away the infected tissue, and you've got bone all the way around it, but it's like this donut of bone loss. So you've still got the labial plate there. This is another example. This is funneling bone loss. This is funneling bone loss on the radiograph. Now, in this situation, we've not got that sort of less radiolucent period, which is the other walls of the defect. We've actually got a very distinct funneling shape. And that's because the buccal and the lingual bone is down here. So you've lost bone mesially and distally, and buccally and lingually is down there. Whereas if it was patelliform, the bone level would be up here somewhere, be far higher up there. Yeah? So that's the difference with those two types of loss. Again, this is an implant taken in June 2007. Maybe starting to get a little bit of that bone loss from around there, not funneling bone loss yet. But now we can see in a this patelliform bone loss, and look, 2007, 2007. So within 3 months, it's gone from this to this, right? Now, there's a number of reasons for that. Patient wasn't looking after it. There'd been some things coming loose. So we'd had an awful lot of bone loss in that period. Now, this implant is still functioning. It's surviving. Is it a successful implant on the scale of Albrechtsen? No, because we've had more bone loss than 2 millimeters in the first year of 0.1. We have got inflammation and infection around that implant, but it's a surviving implant. The patient's happy with the implant, but we just have to manage this condition to stop it from getting any worse. You can see it's got this characteristic less radio opaque border all the way around it. Yeah. Again, this was now, interestingly, because we managed it, it hasn't really changed that much. This is now January 2011. So we've got 7. So this is, how long were we looking? 8, 9, 10, almost 3 years on. And the implant is still functioning. Yes, we've lost maybe a little bit more bone, but it's still functioning and it's going very slowly. Would you take this out? Would you say to the patient, oh no, it has got to go in the bin? No, it's functioning, it's not hurting, he's very happy with it. The rate of bone loss is being monitored, it's not excessive. And in fact, I think I did a bit of, initially when he came back, I think I did a bit of bone grafting there because it was like the case that we showed you. But if that patient went to see some other dentist, they might turn around and say, oh, you've got a failing implant there. You're going to lose that implant in 2 years' time. And it's not realizing that actually that bone level has stayed fairly constant over a 3-year period and nothing needs to be done. And as long as the patient doesn't let the infection come back, there's no reason why it should get any worse. Yeah. Again, an example of this patelliform bone loss. You can see quite clearly the 2 different bone levels and this less radio because of the moat all the way around it. In fact, you can get combinations of a bit of funneling and patelliform. It's not always that clear, but when we look at the mouth, we can see there's inflammation around that tooth. There's mucositis going on in the soft tissues that would make me be concerned. Again, another example here of a peri-implantitis. Now, I'm just going to see if I can zoom in on this one here. Right, and you can see here that the thing that's worrying me about this is that the margin of this crown here has been actually taken down to the implant abutment interface. Now, this is a cement retained crown, but it doesn't look like there's any cement being left there. But it does mean that at this area here, we have a huge, great big micro gap. And that's because when you make a crown, there's always going to be a gap between the crown and the margin. And that's going to be big enough to cause a dead space and cause problems. So even if this patient had very good oral hygiene, you would start to see this effect as a result of that micro gap because there's an infection at that level and the bone is running away from the infection around there. What we should have had is the abutment coming up to about here, let's say, and then you start to make your crown. And the crown margin shouldn't really go more than 1 millimeter subgingivally. And there'd be a lot to be said to actually keeping things, level with the crest as far as possible. All right. So we need to keep the crest as well. Sorry, I just have to wait. My child's just come in. I think she's going to give a comment on things. Anyway, so we've got the margins here could actually be kept supragingival in this area, which would be far better to manage it as a result. So at the back of the mouth, you don't need to bury your margins like this. They can be kept level with the gum margin, and you actually have the titanium abutment, and you can develop a nice submergence profile. But I would say this peri-implantitis bone loss is the direct result of positioning that crown margin too apically onto the implant abutment interface, such that we've got a dead space which has triggered this condition. This is an example of where your restoration has been responsible for everything. Okay. And we can see what's happened here. We've lost bone. This is the one we showed you earlier on, where we've got quite a big restoration. And think back to what I call the cantilevered premolar restoration. And just think from a biological point of view, what's better to keep clean? What's reducing the load on it? Patient has two great big cantilevers here that they have to clean underneath. Whereas the other type of approach is far easier to maintain. This is a picture of somebody that came back with their bridge off. You can see here, example, this is that patelliform bone loss that I'm talking about, that two different levels of radiolucency and radiopacity around there. They've lost one of the abutments completely, the things come loose. This one is starting to show some signs of bone loss. If you really wanted more detail of this, you'd need to take PAs. This again shows a system. Now this is an example of where you've got gap bone loss, and this is definitely a failing implant. You've lost bone from all the way around it. And again, sometimes your peri-implant disease can go down like that. And you can actually see pathogens and like calculus and debris all the way down along your implant surface. And the same here. And this one's starting to lose bone as well. So peri-implant mucositis, the features and I said it's the reversible inflammatory reaction in the soft tissues surrounding a functioning implant, and describes an inflammatory region that resides in just the mucosa. And that was the Lindy here in 2008. So we've known about these conditions for some time. It's not that these are a recent discovery. And within 5 years, it can affect 80% of your patients, with 50% of the implants in the mouth affected. So I go through that again. That is quite a significant percentage of people that are going to have this problem. Diagnosis of peri-implant mucositis is the presence of individual clinical signs of soft tissue inflammation, redness, edema, and bleeding on your gentle probing. If you want to treat this, or the oral hygiene instruction, counseling for smoking cessation if it's due to smoking, assessment of the prosthesis for plaque control, maybe removing the prosthesis for redesign or adjustment, a non-surgical debridement, with or without the use of microbials. It depends on the severity. If it's very inflamed, I'll use some of antiseptic agent, but to be honest, in the majority of these cases, there's no need. Other factors might be the proximity of adjacent implants. If you've got implants very close together, that could make cleaning difficult. Position of the implants in the arch, obviously posterior implants may be more difficult to clean than anterior one. And also if they're going through mucosa, if you've not got keratinized peri-implant mucosa around them, there's going to be issues. Patients should be informed that the peri-implant tissues respond to plaque accumulation in a way similar to that of periodontal disease, and that the disease may develop in the tissues around implants, jeopardizing their longevity. So the patients need to be kept very much informed and aware that they're responsible for this build-up of plaque. It's got nothing to do with you. Poor oral hygiene resulting in plaque accumulation will go on to lead to your peri-implant diseases and your peri-implantitis. Leading on probing of the peri-implant tissues is a sign of inflammation. in the continued presence will result in bone loss if it's not stopped. So you can show the patient. So this is an example of a patient who's come in, and you can see maybe the oral hygiene is a bit questionable around here. I put my probe in there, and immediately there's bleeding. Almost before I took the probe out, there was bleeding. And if you look down here as well, you can see that there is a great deal of calculus buildup. Now, I can remember doing an implant for a patient, and she came back about a month after I fitted the crown. It was a lateral. And she came back and said that since I did the implant, all her teeth had all the gums around, all her teeth had started to bleed, as well as the implant. And this was the fault of the implant. And she'd actually brought her husband along to add some more menace to the situation in the surgery, because she wanted her husband present as well to see what was going on. But when I looked inside her mouth, it was a sea of plaque. There was just plaque over every tooth surface you could imagine. And so fortunately, I was able to start wiping big lumps of this stuff off and explain that it was actually teeming with bacteria, and that this was causing the infection around all her teeth, not just the implant one, and it was due to her own neglect. And of course, she was very embarrassed in front of her husband, but what can you do? And the husband was there, he could see what the cause was, and I could point to the buildup that was occurring. But having said that, when I took the X-ray, you can see that the bone level was quite stable. That's the implant abutment interface. It was still at 2 millimeters. So I was fairly confident in thinking that that was a mucositis. It hadn't really progressed to peri-implantitis and would resolve with oral hygiene instruction. So the treatment of to treat peri-implant mucitis is reversible with early intervention and removal of any etiological factors. Non-surgical mechanical therapy caused a reduction in inflammation and bleeding on probing. You can use adjunctive use of antimicrobial mouthwashes, has a positive effect. Improved oral hygiene, reinforcement of self-performance hygiene. Systemic antibiotics at this level are not necessary. So again, if somebody comes in with this, far too often, dentists will just give them a pack of metronidazole and say, go away, without using it. Now, you can use twice daily use in this paper, a triclosan and 2% copolymer toothpaste was used, and they said it was effective. And then going forward, there's a supportive periodontal therapy. Now, I won't have too much time to actually go through the use of antimicrobials. But what I will say, and what there is there's going to be a download folder for you, and in there there's a paper, and it's about the use of using bleach, and in particular using 0.25% concentration of bleach. And it has been shown that a twice weekly regime of using a mouthwash with this diluted concentration of bleach is very effective at reducing bleeding on probing and preventing plaque buildup. So if you have a patient that is finding it difficult and they've got a full arch restoration or a large restoration that's difficult to clean, then prescribing 0.25% bleach. Now there's lots things like coarse chlorhexidine and things like that aren't very effective at reducing the biofilm. They're not very effective at all. They leave staining. Bleach is by far better, and it's cheaper. It's much cheaper. And the only problem is to find a mouthwash with bleach in. We discussed the other day at the endodontics lecture, somebody was saying about diluting Milton and using sodium hypochlorite to clean out root canals. And it was felt that, there's a product available there, which is, a packaged product, CE labelled and marked for the use in root canals. And if you had a problem with something that you mixed up yourself with diluting Milton, then you'd probably find the medical defence societies would have a difficult time trying to defend your actions, because there's a specially marketed product, CE marked product, on the market for that use. Using bleach mouthwashes, they're not that easily found because of the taste, all the rest of it. There is a bleach which I'll quickly show you at the end of one of the presentations, which you can. It's not sold in the UK, unfortunately, because it hasn't got a CE mark, but you might be able to get it through a circumvented route. It's only available to probably countries outside of Europe. Probably when we leave Europe, it won't matter, but you can see it on the Amazon, and they sell it to actually clean out wounds and cuts. And I actually use it when I'm doing the decontaminating the surface of the implants. I use this 0.25% bleach because it's been shown to be very effective. And again, like the periodontal probe, it's not expensive, and the patients can use it twice a week, and it really makes an effect in keeping their gums and their appliances very healthy. So, supportive periodontal therapy. A systematic review indicated that existing peri-implant mucositis, in conjunction with a lack of adherence to supportive therapy, was with higher incidence of peri-implantitis. So basically, this systematic review indicated that a pre-existing peri-implant mucositis, in conjunction with any supportive periodontal therapy, in other words, nothing was provided, this was associated with a much higher incidence of peri-implantitis. So what this is saying is that if you provide this supportive therapy, your incidence of peri-implantitis will be reduced. So it's another, if you think, indication of how important it is to have these therapies. Now, this is the case that came in with the mucositis. He was cleaned up, he was sent to the hygienist. We did all the things that we said we'd done, and within a very short time, you can see things are looking a lot better. All the staining's gone from the teeth. The thing is now healthy and resolved. If that had been allowed to progress, it would have caused me far more trouble and be a lot more difficult to treat and less predictable. So, non-plaque induced perimucositis. So this is an example of marginal leakage. So there's not plaque here. We've got a very healthy mouth, but not too much. So I can't see build-up of plaque. So why have we got this problem? Well, as I said earlier, this problem has arisen because we've either got a loose abutment or we've got a poorly fitting or loose crown. There's no plaque there. It's purely due to something being loose. It's marginal leakage. We took it off, we can see the results of marginal leakage. Here is another example of a situation where the oral hygiene is there, and for some inexplicable reason, we have a sinus above the margin here. Now, why has that come? Well, most likely that has come either because there was some cement, if it was cement retained, or if it's a screw retained, maybe the abutment's loose or the crown's loose. In these situations, you invariably have to take the thing off, wash it all out. Now, in this situation, I would wash this out with Corsadil, and I would just fill up a needle with Corsadil, and I'd pop it down inside the implant and just gently inject the Corsadil inside the implant to kill off any bacteria that may be living inside the implant. I wouldn't inject Corsadil in the pocket or try to push it into the soft tissues in any way, shape, or form. You must introduce the needle, the irrigation needle, just inside the core of the implant, not poking it into the soft tissue or into the margin, but get down there to wash out any bacteria, kill out any bacteria that could be residing down there. Also, I took a chance to have a look at the crown design. Now, the abutment the actual crown margin has been taken very, very subgingivally. It's quite a subgingival margin. You can see how the emergence profile is being generated by this bulky shape here. This will predispose to pushing the gingiva down. You can see here the patient's finding it difficult to keep clean. There's also been some build-up of breakdown products around here. This is because there's a huge great microgap here, which is predisposing to the collection of deposits. And here we replace the restoration for something which has a nice emergence profile coming up, and the margin, although we've got a margin there, this margin is just under the gum. It's not placed down here like in this case, and we've not got this big fat emergence or submergence profile in our tissue. We've got a nice submergence profile coming up with a polished metal finish on there, and then we've got our crown margin. We're not trying to take our crown margin down to the head of the implant, as in this case here. So this is a situation of where the whole thing had to be replaced, and 1 week later that's already closing up and looking a lot better than it was. This is a situation where we have got suppuration occurring around our implant. We've got a mucositis going on by the looks of it. And again, in the absence of any poor oral hygiene, my immediate thought is there's something loose. There's either cement down there, there's a loose abutment down there, there's something going on down there that we're not sure about, but it's not, it doesn't seem to be induced by any pathogens or buildup of plaque. So I'm thinking there's some sort of prosthetic cause for our peri-implantitis. And when I take the PA X-ray, I can see the bone levels have been quite well maintained. And here, what's happening is that the abutment hasn't been correctly inserted into the implant. And it seems to me like, because this is a submerged implant, that the abutment may have been catching on the bone, and that prevented it from being seated properly. So obviously that all had to come off, and this prosthesis had to be remade, and that needed to be seated down properly. And then everything went back to normal. And you can see here, here's the, it's got a nice submergence profile. It's got a customized abutment. The margins of the restorations are nice high. The only thing that went wrong is the dentist did not position the abutment properly because it was quite deep down and perhaps he couldn't see how it was going. But look at the gingival margin around here. It's nice and clear, any infection. Right. Peri-mucosal hyperplasia. Again, this is where you get a buildup of fibrous tissue. And it is a reversible inflammatory reaction in the soft tissue surrounding a functioning implant. Again, that was Ayman and Burgundy 2008. And it describes an inflammatory lesion that resides in the mucosa again. And within 5%, within 5 years, affects 25% of implants. And greater than 60% of the subjects had peri-implantitis as well. And in 12% to, and that occurred in 12 to 43% of the implants. So again, it's a significant finding. I don't get to see that much of it. This is the case that I showed you earlier on with the fibrous hyperplasia going on around there. There's a mucositis, it's triggered that off. It can be associated with bone loss in the later stages. When this happens, you have to get on and treat it fairly early on because it will progress, and it looks quite nasty. And as you can see, it's all this tissue all around the back, all around here. It's going back over the tuberosities. It's covering there. If we look in the mirror view, you can see back here how this fibrous tissue has actually overgrown the restoration, and it looks like it's going to engulf the restoration. On the other side, it's clean as a whistle, clear as a bell. But on this side, and you can see it's always very well demarcated. You can see here, there's this line. Now, It's going all the way around buccally. You have to be a bit careful when you remove the buccal bit that you don't remove too much attached gingiva. And the only way to treat this is, I say to the patients, I'm going to give you a sort of gum haircut, and I have to just do a gingivectomy as if you're treating epineutin hyperplasia and just remove all this fibrous tissue. And I see it more frequently on patients that are using some inhalers, cortisone inhalers, or they're on blood pressure tablets, or something like that nature. And of course, I find it on full arch restorations. And so the treatment of this is surgical removal of this hyperplastic tissue, improvement of their personal hygiene, and maybe the adjunctive use of cortical gel. And you modify, if necessary, you might have to modify the design of the prosthesis so it's easier for them to keep clean. Cortical gel's okay, but if you can get hold of the bleach mouthwash, I think that's a better thing altogether. And this is the sort of stuff that you'll pull off from around here. So it's quite a significant amount of tissue. There's no way that tissue is going to disappear or resolve of its own volition. You have to get in there and just cut all this off. Okay? So, as I say, it will result, if untreated, it will result in bone loss. So what you'll do is you might find just a little bit, the patients might have a full arch restoration, and just around one tooth possibly, there's just this hyperplastic reaction going on, and you just have to get them in and trim that off. This again is a situation going on in the thing. You can see there's quite a lot of build-up of this this hyperplastic tissue. And then I've taken the bridge off, and we can see, and in this case, sometimes I take the bridge off to do it, and sometimes I cut around the bridge. It really depends on whether I think it needs to come off for better cleaning. And this particular case, we took the bridge off, the lower bridge off, and you can see how hyperplastic and edematous that tissue is. And this is it. You can see, looking from the occlusal view, all this tissue and that line, you can almost follow it around, can't you? Here, look, there's like an island all the way around. And here, it's quite a big island. It's quite satisfactory, you know, to actually, satisfying to actually cut all this stuff off, right? And you can see it again from this angle, again, all that hyperplastic tissue here. And this was in the lower as well. And this is it in situ after we did the trimming. Now you can see that unfortunately, this was also associated with bone loss. We have horizontal bone loss. We have the patelliform bone loss there, maybe patelliform there. We lost an implant back here. We'd also lost one from here. This patient I placed these implants. Obviously, when I placed them, they were all level with the bone. It was the good old days when you planned them by the seat of your pants, and you can see I was probably quite close to the mental foramen there. And when I treated her, we did this at immediate, and the reason we extracted all her teeth is because she had gross periodontal disease. So this was a lady with gross periodontal disease, but at the time we didn't know that this was going to be a problem, because we thought, we'll get rid of the periodontally involved teeth and that's it, you've got rid of the periodontal disease, and then just see her when we need to see her once a year to check the prosthesis hasn't come loose. Well, that was living in a little bit of ignorance. She should have been seen every 4 months to keep on top of it, not after a year and a half, because then you get this bone loss to deal with. So the positive side of this story is that after a few haircuts and a lot of adjunctive and supportive therapy, she's now seeing a hygienist every 3 to 4 months to maintain her condition. And she did see one other hygienist who saw a bit of hyperplasia and went into epileptic sort of shock over it. But then I did point out that this has been like this for 30 years. So once you implement the therapy and you stabilize the condition, yes, you have to do maintenance. It's always going to need maintenance. She's going to have to come back every 3 to 4 months. But this lady would rather have a fixed set of teeth that she's had the use of for nearly 30 years than a denture. Yeah? And we're now keeping the disease under control. But it would have been nice if we'd prevented it in the first place. This is another full arch case, and this was a case where we'd done hip grafts and block grafts and all sorts of exciting things because she had a really severely resorbed atrophic maxilla. And you can see she's actually got debris collecting between and around the implants. And we took it off, and you can see the amount of debris and stuff that's collecting. Now, she was a patient that I'd seen, had left me for a few years, was being seen by a local dentist who did nothing to maintain it, just looked at it and said, oh, that's okay, go away. But you can see here the amount of build-up of plaque and stuff that's building up around there. You can see all that crud, all this build-up here. I mean, no wonder she's losing bone. It'd been completely neglected. She hadn't seen, I think it almost been 5 years that she'd had anything done, and then she comes back with this situation. So again, this patient was now concerned that they were losing bone, that they were losing the dentist had now told them they were failing. And what we had to do was take this all off, clean it. We then tried to replace the lost tissue with some pink to try and make it easier for her keep clean. You can see how we've tidied it all up. This represents, all this pink represents all the soft tissue that she's lost, because obviously she's lost bone, and as she's lost bone, she's lost soft tissue. She's lost soft tissue has gone with it. It hasn't become replaced by hyperplastic tissue. So this now is tissue she's lost, and we want to try and keep it clean. So now we're keeping it clean, and yes, she has got screw threads in the mouth. And so I count the number of screw threads there, and yes, she has to keep these areas clean on a regular basis. But the alternative would be to remove all her implants and start again. Now, the patient has been maintaining this in this state for the last 8 years with no problems at all. So she's now maintaining it again. She's on a regular maintenance to keep all this down. Maybe there's a little sign here, just in this area here, there's a little sign of this mucositis hyperplasia just starting to creep in. So you keep an eye on that. And at some stage, she'll need to come back and have a haircut around there just to sort that out. Maybe there's a little something going on there. But this is the situation. And I say those implants now, although they've got that recession, there's quite a bit of recession, at least 2/3. If you do the percentage, remember I said 25%, 25 to 50%, 50% is severe. Well, these have got over 50% of their bone, haven't they? This one has got over 50%. And this is one of the advantages of using long implants. Yes, you can use a 12mm implant a lot of the times in the maxilla. But when I'm placing implants in the maxilla, my favorite implant of all to put in the maxilla is a 15mm. And again, I might do 12s down here. And that's because the maxilla is more prone to bone loss than the mandible. It's more prone to peri-implant bone loss for some reason. Same as it's more prone to bone loss in periodontal disease because of the nature of the bone, its origins makes it more susceptible. But that being said, if I lose, say, 25, if it's a 15mm implant, then 25% of a 15mm implant is about 2 or 3 millimeters. But 25% of a still leaves me, if I lose, say, 25%, which is, say, 3 or 4 millimeters off of a 15, I still have 12 or so millimeters of implant in there. But if I lose 25% on a smaller implant, then the percentage is going to be worse. I don't know if that's made any sense, but basically, when you're looking at the percentage of bone loss, you want to be in a situation where you've got at least 50 to 60% of the implant still in bone. And if you start with a longer implant, that's going to mean you can afford to lose a little bit more bone, but still have a restoration surviving like this because of the long implants. And this is the sinus graft up here. There's been a sinus graft up here. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9. And sometimes in the grafted cases, I go overboard with the implants because I know implants in grafted bone don't tend to do as well sometimes as in native bone. So this situation, as I say, has been ongoing for many years. If you look at it, it's not ideal, it's not textbook, but it's functioning, it's working, it's stable. A patient is happy. Look how clean look how clean she's keeping those surfaces of those implants. Yeah. All right. Peri-implantitis. Inflammatory reactions associated with the loss of bone around a functioning implant. Again, these have been known for a while now, over 10 years. And it describes an inflammatory region that resides in the bone. And it's a chronic disease, although it's quite rapidly progressing. Peri-implantitis is often accompanied by crater-like bone defects around the implant. Peri-implant defects normally encompass the full circumference of the implant. And the bone loss pattern can be subcrestal alveolar bone loss, intraosseous alveolar bone loss. Intraosseous defect configuration can impact on treatment outcome following the regenerative protocol. So this is a situation where we've had supracrestal bone loss. This is the start position. This is what it looks like from an occlusal view, but we've lost horizontally, we've lost bone, right? Now, when you get this type of situation, there's no point in bone grafting. This was like the one we saw. You cannot build up horizontal and keep vertical bone. It's the holy grail of implant dentists. And I often see implant dentists thinking they can sort of put bone up here and put a membrane on it and it's going to stay. It often doesn't stay. I've never seen it work, never ever seen it work. I've never seen a convincing set of papers on it. This is a situation where we haven't lost any horizontal bone, but we're getting intraosseous bone loss. And we've lost a bit of the buccal plate. And this can sometimes happen, perhaps, if you place the implant a bit too close buccally, you've had a thin plate of buccal bone there to begin with, and superimpose on that the fact that you haven't maintained the oral hygiene, and you lose the bone there, and you might, this sort of fenestration type of defect. And again, you might get this rather fuzzy looking area around when you take the x-ray. It really depends on how far that goes around. Now, this is that patelliform where you've got a moat of bone lost from around the implant, but you've got bone, buccal, and lingual at the right height. This one's showing a little bit of crestal. The bone level should be up here. Maybe the diagram's not that good, but it's all interosseous, and this will show you that very, diagnostic radiographic appearance, this patelliform bone loss. Here we've got some loss of the buccal bone, and now it's extending in, and it's going around again, interosseous bone loss. This is going all the way in, and it's all the way around that implant where you've lost bone, all the way around, but it's still attached at its base. It's still attached at the base. So it's still, and then it can go all the way around, and it can go like a through and through, and that can be at different levels. So you've got the bone higher on the mesial and distal. So you can see, you can get quite a variety of different types of interosseous defects. Now, the problem is, if you want to stand any chance of getting any re-osseointegration around these implants, you have to decontaminate the surface, because the surface will be covered with pyrogens and toxins. So if you just take out the soft tissue, but don't clean the surface of that implant somehow, then you will not get any kind of attachment or anything happening to that implant, because you've still left a layer of pyrogens, which are bacterial proteins and end products, smothered all over that surface. Surface of that implant is absolutely filthy. You're not going to get a graft reattaching. And this is why this idea of new osseointegration or neo-osseointegration is, I think, a bit misleading and a bit of a fallacy. So most defects, both bone defects, are caused by peri-implantitis, affect more than one surface of the implant. In determining the severity of the bone loss on two or more surfaces of the implant, you can perhaps use bleeding, you can use a probe going around it, but you have to try and work out, and sometimes when you lift these flaps, you end up going all the way around the implant, and you find nooks and crannies and buried things, and it can take quite a bit of time. In fact, it takes longer to do this than to put an implant in. And then that starts you to think. Well, should I not be removing this implant and just put in a brand new implant? Because I cannot guarantee that I can decontaminate the surface of that implant. I have no guaranteed process of decontaminating it and getting it back to the same level of cleanliness that it was when it came out of the factory. Yeah? If an implant is positioned too far buccally, bone and soft tissue loss may not be bacterially induced. This may be a rationale requiring at least, this is the rationale for requiring at least two aspects of the implant to be measured. So when you're going around, you want to measure at least two aspects of the implant, the buccal and the lingual. You can normally see on the X-ray quite clearly the mesial and the distal bone levels, but the lingual and the buccal surfaces you can't see, and you may need to use a probe there because it might look all right mesio-distally but dips down mesio and distally. Technical points: buccal and lingual levels can not be determined from a periapical radiograph. You can't see them because the implant itself blocks the level of the bone. You can only see the mesial and distal. If you need to really examine it with probing, you need to use an LA and actually numb the patient up before measuring these, because it will be painful if you want to penetrate to the lower levels of where the bone level is. So peri-implantitis signs and symptoms: well, we've got color changes in the keratinized gum tissue or in the mucosa, bleeding on probing, increasing probing depth of peri-implant pockets, suppuration, peri-implant radio transparency, remember this patelliform, and progressive loss of bone height as well around the tooth. You can get not just intraosseous defects, but also you get this horizontal change in the bone as well. Remember the classification of peri-implantitis. You've got a mild, moderate, or severe, and this is worked out on the percentage of the bone loss. And what I will do is I will add perhaps a clip of this into your box as well, so you can read that, because it's talking about the pocket depth as well as the percentages. But I look at the percentages more as well, like up to 30%, it's early, so that's 20. If you're going from 25 to 50%, then it's moderate or advanced, coming on then at over 50%. And then this here tells you the surgical strategies that you should be adopting when treating these kind of defects. So periodontitis and peri-implantitis, the aggressiveness of the biofilm and the concentration of anaerobic bacilli increases with pocket depth. So the deeper the pocket that you have either around a tooth or around an implant, the deeper that pocket, the more aggressive the effects will be felt. So a biofilm in a shallow pocket will have a less aggressive effect than if you have a biofilm on a deep pocket. And that's why people with deep, or patients with deep periodontal pockets, can be very prone to further attacks with very exacerbated amounts of bone loss, very severe bone loss in a very severe time, because the ferocity and the fierceness of that inflammatory response in the deep parts of the socket, which are anaerobic, is far greater than in a shallow pocket. So basically, this triggers inflammatory responses. You get the bleeding on probing again, you get attachment loss, bone loss, and tooth or implant loss as a result. Treatment of peri-implantitis, early implementation is essential. So just like trying to prevent it by having maintenance regimes, by having supportive periodontal treatment, as soon as you start to see it, you've got to stamp on it straight away, because now this is non-reversible. You can't go back. So control of peri-implantitis treatment aim. Control of the infection first and foremost. You may have to detoxify the surface of the implant. And I find the best thing to use here is bleach, right? And you can use here, what I would use is get the bleach that people use for root canal therapies. Yeah, all right? And what you do is you put that on a pledget of cotton wool and you rub it around the surface of the implant. There's lots of other people that use phosphoric acid, they use citric acid, they use all sorts of concoctions. But the only thing that's really good at destroying not just the bacteria, but also removing that biofilm is bleach, right? You want to prevent the progression and halt any more bone loss. That's the whole point of this. You want to try and regenerate the lost soft tissue, and if possible, try and do something about the hard tissues, but that's a bit of a goal that's not always possible. You might want to do a little bit of grafting if you think that that might fill in a bit of a defect and make it easier for the patient to maintain, then that's all well and good. Re-osseointegration or neo-osseointegration of the exposed implant surfaces, that's a goal. I think it's an impossible goal because I don't think you can ever get the surface clean enough to be able to achieve it. And you want to try and develop a mucosal seal around everything. Then protocols for treating peri-implantitis. Pre-treatment phase includes assessment and establishment of good oral hygiene. There is no point going in and doing any grafting or membraning if the patient isn't maintaining things. All right, so they've got to show at least a couple of months of maintaining things. If they don't, and if they're smoking, they just have to give up the smoking, because you're just wasting your time. This is already not a predictable treatment. You know, you're already on the last, you're on your last gasps here. You've missed the chance to stop it at mucositis. You've missed the chance to stop it early in its progression with early bone loss. And now you're starting to get bone loss. And the problem is you've got a contaminated implant surface to deal with. In the other things, in mucositis, you don't have a contaminated implant surface. So it's very, very difficult to clean that contamination away from the implant. So anti-infective treatment, including surface cleaning achieved by non-surgical access. So you lift back the flap maybe, and you use a bit of that bleach on the surface. If you can see calculus there, then you have to remove the calculus. And people get very worried about using a metal instrument, about it doing something to the surface of the implant. Well, if you've got a great big lump of calculus on the surface of the implant, I'm sorry, the surface has already been ruined, and you scraping it with a metal instrument is not going to make any difference at all to that surface at this point. But leaving a great chunk of calculus or not cleaning it properly will make the stabilization of the situation far more difficult. If you can stop any more progression and halt it in its tracks, except the little bit of bone loss that's occurred, then that's the best you can achieve. And then you've got to implement supportive therapy, and they've got to come regularly. If you don't do that, then you've lost. This is in mild. Now we're looking at mild. We've got our bleeding. Also, interestingly enough, we've got bleeding around there. We've got this bone loss, looking like there's a bone loss. This is probably a little bit of buccal bone loss, thinning of the buccal plate here. but the implant's still firm. This might be one which you think, oh, this is going to fail. Now with this one, because I've got some bone loss occurring here, I implemented oral hygiene instruction, and what I'm doing now, the crown and everything's been taken off, it's been cleaned, I've repositioned the crown, and now I'm using dentamycin around that because I've got a bone necrosis going on, an osteitis of the bone. I'm going to use this, and I might bring I give this to the patient, and sometimes I show the patients how to use this themselves, and they apply it at home. This one, you can see we've actually applied it around there, and it's actually come out through the sinus, because there's actually a sinus developed around here as well. So I'm injecting it around there, and you can see I've done it all over the thing, and I've got it coming out through the sinus as well. And that all resolved up fairly nicely because I caught it in the early stages, or the early to moderate stages. Now we've got our OPG here. I'm just going to think what this relates to. Oh, this is the situation. I think this is the patient here. It's obviously not the best of all hygiene going on here. We've placed our implant there, and as I say, I've done my more favourite one with a cantilever. And these I find go on for many years. Now look at the situation here. Look at this plaque. Look at this. Now this is going to be peri-implantitis. Yeah. Look at the build-up of the calculus and plaque on that cantilevered restoration. This is bleeding from around that restoration. This again is a case where there's moderate. The patient was a smoker. This patient was a smoker, and she had some implants placed in this area, premolarized occlusion. But you can see when you pressed it, there's actually pus coming out of it. I can press it there, and you can see you can actually milk it and collect the pus. I took off the restoration, and you can see the amount of suppuration that's going on here. Now, in these cases, what I sometimes do is I unscrew the abutments and I send everything back. I put it all in the sterilizer, decontaminate, then send it all back to the lab for cleaning, look at the restoration again, see if that can be modified. And I put fresh healing collars on there, and I irrigate the site with Corsadil, and I put healing collars on there to maintain that. This is the bridge that came off. You can see the amount of debris and stuff that's around all of that. That all goes back for professional cleaning at the lab. But you can see they've been luckily she had one of those genetic types where she was fairly resistant, even though she was a smoker and had let it get that bad. So now we have severe loss of bone, and you can see this gap bone loss all the way around here. Now these cases, they're not salvageable. When you've got severe losses, you can't manage it. You see there's threads exposed. Just look at the oral hygiene. This chap was, I think, a drug abuser, plus a smoker, plus didn't clean his teeth. So he is, no matter, and this happened, I think the implants had been in for about 15 months. So this was 15 months after the restoration. And when these restorations went in, there was gum here. Now look. And this is how it all, and you can see the infection going, because there's been gap bone loss all the way around, you can see the infection's gone all the way down. You can't decontaminate these implants. You can't do anything other than remove these implants. These have failed. This is a situation where the patient had moderate oral hygiene, but the restoration, you can see the restoration here, there's a great big lump of acrylic around here, and this is where the margin, and this had been taken, this lump of acrylic had originally been more subgingival, and the gingiva had been up around here. Well, the gingiva can't survive that. And when you press on it, you can see the suppuration. And there'd actually been a lot of buccal bone loss in this area. In fact, when I lifted back the flap, you could see all the implant was exposed buccally. There was no, so it's in that case where we showed earlier the diagram where the bone had all been lost around there. But when you looked at it on the PA, you could see, look, mesiodistally, the bone looks great. Maybe palatally it was okay as well. But on the buccal surface, the bone was around here somewhere. But because that was so well integrated, we decided to clean it, decontaminate the surface, and put a graft over the surface of it, not for new integration, but purely so that the patient could keep it cleaner. And of course, we changed that restoration so that it wasn't predisposing. But also, I think in this case, the dentist had put quite a wide diameter implant in. And again, this implant had been placed some years ago. It's an old Friarlet implant. So it's probably been placed something like 20 years ago. And at that time, we thought that if you put an implant in, it should be matching the diameter of the root that comes out. So, you know, you'd like, if you had a 12 millimeter diameter root, for example, you'd want a 12 millimeter diameter implant because you wanted to limit the gap between the implant and the inside of the socket. We now know that that's the worst thing to do because it triggers off resorption of the labial plate, and you need at least a 2 millimeter safety gap between the labial plate, the inside of the socket labially, and the surface of your implant. And you should have that gap, and you shouldn't rest the implant on the labial plate. That just goes to show how thinking changes. And if we look at the CBCT, we can see the bone's been maintained up there on the platal aspect. It's a good long reach. It's all very well integrated down there. But here in this section here, where the bone had been very thin, or maybe the bone was there, but as I say, because the implant diameter was too great, it caused bone loss, coupled in that the prosthetic design wasn't that brilliant, had resulted in that peri-implantitis. And this is looking at it just a little bit further along and showing the bone loss around there, but good, look at the nice good palatal bone and a good thickness of buccal bone there. But the buccal bone, if that's our palatal bone here, you'd expect the buccal bone to be here, and most likely on the original it was here, and the lady's lost that amount, and that represents where the acrylic is on the restoration, because obviously there'd been a lot of tissue loss, the soft tissue dropped down, and the dentist needed to cover up the metal abutment. So regenerative surgery, when implant scaling and local antimicrobial therapies have failed to halt the progression of peri-implantitis, surgical debridement may be indicated. So, you know, you've actually got to go in there and start removing stuff. You've got to maybe remove soft tissue, debride soft tissue. You lift full thickness flaps are needed. And I say this is quite an extensive procedure. So you want a full thickness mucoperiosteal flap to allow thorough cleaning. And you need that not just to be able to get rid of any infected tissue, granulation tissue, but you also need it to be able to try and get in and clean the surface of the implant with whatever you're using to clean it. I say I like to use bleach on cotton wool pledgets, and sometimes you'll find there's also bits of calculus or stuff on the surface of the implant. All that has to be removed. And then you want stabilizing of the osseous peri-implant defect with a bone substitute. Will that bone substitute osseointegrate onto the surface of the implant again? Highly unlikely, highly unlikely. What that is doing is it's just filling up a bony defect so that you don't get all that granulation tissue growing back in there, and it's easier for the patient to maintain it because you don't want a load of soft tissue down there. And it's going to reduce, if you like, the possibility of a soft tissue pocket. So if you had like a vertical defect in the bone of 4 to 5 millimeters and you filled that in with a graft material, then that means your periodontal pocket depth afterwards is going to be that less deep. And as I've said, the deeper the pocket over 4 millimeters, the more aggressive the effects of any biofilm, because it's more anaerobic and very much more difficult to keep clean. So you're reducing the pockets by putting in the graft as a filler, but don't fool yourself in that you're getting new osseointegration on the surface of that implant. It's not happening. Yeah. Post-operative anti-infective protocol, a pre or post-operative systemic antibiotics. Again, I tend to give a high dose of antibiotics, and I quite like azithromycin, which is an erythromycin antibiotic, and you can get that as 500 milligrams, and that's my drug of choice. It's got a low, there's not many people allergic to it, and it's excreted in the cervical fluid, and it's just a very nice antibiotic. So I might give them 3 of those, one to take one each day for 3 days, and then that should cover it. Chlorhexidine mouthwashes you can use as well, but again, if it's a really severe case, I might fancy them using chlorhexidine for a few days and then shift them across to the bleach, because it's so much better than chlorhexidine. And chlorhexidine has been associated with allergies. So bleach is much better. So 3 to 6 months maintenance, including oral hygiene and removal of that supramucosal biofilm, absolutely essential. Successful outcome, well, ideally you want complete resolution of inflammation and you want to preserve the soft tissue. You're never going to turn the clock back to when you first fitted the restoration. So if the patient's expecting it to look like it was when it first went in terms of soft tissue level, you better tell them that's not going to happen. Establishing a healthy peri-implant tissue environment is difficult, since inflammation will still be present in a significant number of patients. So it's still very difficult to get a successful outcome. And, you know, some of the papers I've looked at long term have only shown up about 25% success rate in all these really what I call heroic attempts. So I really feel if you're approaching above 50 millimeters of bone loss, 50% bone loss, yeah, I think you need to start considering implant removal at some point and just start again. As a chronic disease, retreatment may be necessary, so you may have to go back and do this more than once. And successful outcome, implant survival with mean probing depths of less than 5 millimeters you need to have to try. So at the end of this, when you probe, if you can't see that black line, then likelihood is it's going to come back, right? Sorry to say. So if that black line is disappearing, it's a waste of time. It'll probably come back, and your best bet is to just replace it. That's why it's best to catch it early. Peri-implant is associated, as I said, afterwards it's going to be tissue recession, so they may show more metal on the abutment. It's common following this kind of treatment. So if it's in the aesthetic zone, you're going to have some issues to deal with, especially if they've got a poor biotype. Post-surgery complications, if you're using a membrane, well, obviously the membrane can become exposed, and I tend not to use membranes in these situations. I prefer to use something like, you know, you could use BioOs, which is a hydroxyapatite, because you're not trying to get osseointegration, you're just using it as a bone filler. And BioOs and these hydroxyapatite bone substitutes don't resorb, so you don't really need to protect them from the oral environment. And you're not going to actually, somebody's come unstuck again. I think their microphones come on, just, I'll see if I can switch their microphone off. Hold on a second. Right. Right, so basically, outcome of non-surgical treatment is unpredictable. As I say, if you've got a severe lesion, you've got to do open debridement, including surface decontamination. It's more effective in the treatment of peri-implantitis than closed debridement. Primary objective of surgical treatment in peri-implantitis is to gain access to the implant surface for debridement and decontamination to achieve resolution of the inflammation. We want to get rid of those bacteria. We want to reduce the bacterial load. We want to remove the biofilm. We've got to look at adjunctive chlorhexidine application, but it's only got limited effects really. I think the best thing to do is to use this bleach mouthwash. Adjunctive local or systemic was shown to reduce the bleeding on probing and pocket depths, because again, this is an infection of the bone. So we need to treat that bony infection. And there is no evidence, this is a thing, there is no evidence that regenerative protocols had additional beneficial effects on treatment outcome. So using all these membranes and things like that, and all these things that you read, there's no evidence that they really have that big a beneficial effect. So I think the best you can hope for is to actually fill in the depth to remove that, reduce that the depth of that periodontal pocket, so that the patient can maintain things. But when you're getting to this more advanced level of bone loss, I think you just have to accept that you've got a failing implant under the old definition, and it's just a matter of time as to when you're gonna that implant's going to be removed. So considerations: open debridement, including surface decontamination, resolves peri-implantate and promote bone infill, and could result in reossigation. It could. I think it's highly unlikely, but this is the sort of things they say. Reosseointegration was more pronounced on rougher surfaces than smoother surface implants. Again, some people have said that, but the problem with rougher surface implants is they're harder to clean. They're harder to decontaminate. No single method of surface decontamination, whether it's chemical agents, air abrasives, or lasers, has ever been shown to be more superior. Adjunctive use of graft materials with or without membranes resulted in varying amounts of bone infill and reosseointegration, but the effectiveness influenced by the size and morphology of the defect. So the smaller the defect, the better result you're going to have. Limited evidence that surgical treatment and implant surface decontamination plus systemic antibiotics will resolve a number of lesions. So there's not, after you've done all this, there's limited evidence to support it, and no evidence that regenerative procedures, bone grafts, substitutes, guided bone regeneration produce beneficial effects on treatment. So all we can do is a sort of palliative thing, right? So our successful outcome, all we can look for is ideally complete resolution of the inflammation and preservation of what you've got. You don't want it going further forward, get in there early. Establishing a healthy peri-implant tissue environment is difficult, since inflammation will always still be present in a number of patients. You can never 100% get rid of it, but you've probably got more chance the sooner, the earlier you catch it. As a chronic disease, retreatment may be necessary. Successful outcome and implant survival will be worse where you've got deeper bone depth. So this is what I'm trying to show here. And I'm just going to basically show this last thing, which I'll probably put this slide in as well. There'll be a couple of slides will go in the download box. But what I'm trying to show here is you've got peri-implant pockets, which are less than 4 millimeters with no bleeding, often need no therapy at all, just all hygiene. Again, if there's no loss of bone, but some plaque, again, all hygiene, that's going to be great debridement. If, on the other hand, you get peri-implantitis and you start to get pockets greater than 4 millimeters, you then have to move to doing a surgical approach, because your normal cleaning approaches won't get you access. And then you've got, depending on the amount of bone loss from the baseline, you've got mild, moderate, or severe, up to 25%, 25 to 50%, 50%. Most likely with 50%, you're looking at extraction. If you've got moderate bone loss, you'll be looking at open cleaning and grafting. And if you've got mild, again, you'll still be doing all the surgical resection